Alrighty.
All right. How's
Yeah.
that?
That's a lot better. Yeah,
that-
there's some technical difficulties with these apps sometimes. No worries at all. So so we're back, everybody, and I think Dr. Van Heest was starting to say about some of the things virtually that are occurring at University of Minnesota specifically.
Yeah, so we've taken a four-prong approach to the resident selection process. So we have 10 U of M students that are with us, and we are making sure that they have 2 rotations where they can get strong letters of recommendation. And then we have 2 students that have received diversity scholarships to come join us for an experience this year, and we're having kind of a custom program for those 2 individuals. Then we have 50 people who have applied through VSAS for away rotations, and we have 3 different rotation dates set up, and they're in 3-week segments. So they're August to September, September to October, October to November. And during those rotations, what we're planning on doing is that you will be assigned to one of 4 different sites. So either to our VA, to our level 1 trauma center, to our university, or our children's hospital. And then you'll be able to do whatever time commitment you have. We're thinking probably about 10 hours total, because we know med students have other commitments. But we'll give you an opportunity to meet with our residents at that site, to go to their conferences, and then to do a case presentation and participate in a journal club. So that's your networking opportunities. So you get to meet residents, you get to meet the faculty, and you get to do a little bit like you would do if you were on an away rotation, which we think is really important.
Oh, that's absolutely awesome. And is it open to pretty much anyone at this point? Are there certain criteria you're going to use? And are those criteria you would use for this sort of four-pronged approach you're talking about similar to what you're going to use as far as what you look for in potential or prospective residency applicants? Yeah,
so at the present time, we have 50 people that have signed up for it, and we do have a waiting list. And then the fourth prong are for people who are interested in applying to our program, but either don't have the time or the commitment or able to get in on the virtual experience. So next week, I'm doing a town hall for an open forum asking about our program. And we can post that on Ortho Mentor for the information to sign up for that. And that's open to anyone. And then we'll be taking people through the regular ARIS application as well. So that's the fourth prong.
That's absolutely.
We aren't changing what the way we select residents in that we have the same criteria as previously, sure. But we're just changing the methods by which we use. So it's going to be interesting. And then the virtual interviews will be interesting as well.
Yeah. So how do you, this year, without this sort of a way to kind of give you a keener sense, obviously sounds like you've got some great opportunities lined up for students, but let me ask you, do you think that the metrics that you're going to be looking at, or the metrics by which you focus on students, does that change? Are you going to be looking at some things more so than others this year? Are you going to scrutinize personal statements more? Are you going to scrutinize the MSPE more? Are there various facets of the application that y'all are going to be looking to a little bit differently at Minnesota anyway, that you may not have put emphasis on in prior years?
Well, I think in prior years we knew people because we had 10 of our own students, plus last year I think we had 42 away students.
Wow.
And so if you have that many students that you know personally, right, then obviously that personal connection is a lot more of the application. So I think not the paper application, but the right, ARIS application, plays a lot more importance because although we'll try to connect through these, virtual rotation and the town hall and our virtual interviews, honestly, it's not the same kind of personal relationships that we've had in the past. So we're going to need to, out of necessity, right, rely a little bit more on the ARIS application. So I think spending time for the students to think about their personal statements and make sure that they're clear, and even write a separate little section, since you're limited on the number of applications that you'll do. I think putting a personalized section on each application and why that particular program is of interest to you would
Hmm.
be of great benefit. Um,
And that's a great point. And someone actually texted me today um, about that. And I actually, too, at least because we have 18 coming from Miami this year, and I'm telling all of them that regardless of the strengths of their application, that if you have certain programs you're particularly interested in, you should definitely include a little bit of a personalized, some program specific statement of sorts and why, having thought about it very carefully. So with that in mind, are there certain things with regards to screening cutoffs? Are there certain things? Is that changing at all for you? Are you kind of opening the floodgates a little bit? Or are you being even more stringent this time around, knowing that those away rotations that typically are there and are helpful aren't there this time around?
yeah, we aren't really changing our criteria. We've always used 235 and above for our USMLE scores. To
Okay.
us, that's a screening tool that you
Mhm.
have adequate medical knowledge. And then after that, it's all about, professionalism and commitment to the profession and accomplishments to date. So our criteria haven't really changed. It's just the methods by which we evaluate those, because we have less personal relationships with less face-to-face time and more
Sure.
Zoom time.
Right, right. And the one thing I kind of space on it for a second, I want to ask you: are you suggesting to the students from University of Minnesota? Are you suggesting that they limit the number of applications they submit? And how do they make that determination? At least at UMN specifically, and how might you suggest that other students go about that, sort of figuring out how many programs they should apply to at outside institutions?
My understanding is that it's a national recommendation of 60 applications, and that the program directors across the country have agreed that 60 applications if your board score is 235 or over. And the reason for that is it helps level the playing field. Because when we get over 700 applications and people are just checking the box and they don't have a specific interest in our program, then it's very difficult for me to give a personalized, in-depth view of every application. But
Right.
if the medical students each limit themselves to 60, that should
Mhm.
lower the overall number that each program gets. So you get more attention from that program, and that should give you a better chance uh, for uh, for your application.
Yeah, and that's wonderful to hear, because I mean we're doing the same thing in terms of, and especially with so many, we've got to be cognizant of higher tier students boxing out lower tier students as well. So I think that's a great thing in particular. So at University of Minnesota, I want to showcase the program a little bit. Is what would you consider are the top three highlights of the residency program in your mind?
Yeah, so there's kind of three different things. The first thing is the multitude of different sites. So we call it a smorgasbord of orthopedic education.
That's
The
great.
second thing is our simulation program. And then the third thing is the diversity of our faculty and our students. So I'll just start first with the smorgasbord. So we have 6 different sites. We are the only residency program in Minneapolis, St. Paul. So we have 5 million people. We have 2 level 1 trauma centers. We have a full-time pediatric hospital, plus our university hospital, plus another children's hospital for trauma.
Wow.
We have a VA medical center that does more total joints than any other VA in the country. Uh, and we have our university hospital with all our subspecialties.
Wow.
So I think it's a time in your life when you want to get as much exposure to as many different sites as you can. And
Right.
so by having, we're 8 residents per year, and our rotations are every 3 months. And then during your subspecialty year, it's every 6 weeks on a different subspecialty. That's your 4th year. But you get to know the cohort of your own class because you rotate as a group of 4. So in that way, it's small. But in another way, it's very large because you go to 6 different hospitals, you learn 6 different systems. But this
Right.
is your time in your life to do that, and it lets you
Right.
come to the smorgasbord and kind of take a
Right.
taste,
Right.
see what things you like.
Right. No, that's a wonderful take, and one thing that I kind of wish I had done, and I want to encourage all the students out there looking at programs, is trauma is so critical to it's so fundamental to orthopedics that when you get a great trauma experience, and it sounds like you guys get a robust trauma experience, that that is really what allows you to bail yourself out no matter what specialty you go into or subspecialty, whether you're doing foot and ankle like myself, and like Dr. Van Heest, joints or otherwise. And I think that's something that's really critical and should be looked upon strongly no matter what kind of program you're looking for in particular.
Yep, and we have 2 level 1 trauma centers, and so you get a little bit. You get the Hennepin program, which is led by Andy Schmidt, where the original Gastillo classification started, and we have the Regents program, which is run by Dr. Peter Cole, and we have 2 very high level groups of trauma, but they run their trauma services differently. So again, even within trauma, you get to taste different flavors of trauma and different ways to run that.
That's super awesome. Tell me a little bit about and especially because I know there's lots of female medical students who I've engaged with who are popping up. Tell me about the diversity and sort of the diversity of the faculty, the residents, and so on too up at University of Minnesota.
Yeah, so I think the aspect of University of Minnesota that I'm most proud of is that we've had over 25% female medical students for over 10 years. So if we look back 15 years, so since 2005, we've had 26% female medical students and 20% underrepresented minorities.
Wow.
And so I think as part of that, we've also cultivated faculty members. So now our faculty similarly is about between 20 and 25% female. And we have 3 vice chairs, vice chair of research, vice chair of clinical, and vice chair of education, and all 3 vice chairs are female. So I think for female applicants, you will have a very strong role models. You have people, there's a lot of different ways to be an orthopedic surgeon, and there's no one right way. But I think it's helpful to see, some people have no children. Some people are married. Some people aren't married. Some people, have had children during residency. Some people have had children before. Some people have afterwards. And there's a lot of different ways to do it. So I think just being able to be exposed to the many different aspects that, it's not novel because many of us do it. And so I just think there's a lot of really good role models. So I'm proud of the number of people that we have and the number of different ways that you can choose to be an orthopedic surgeon.
That's absolutely amazing, and it goes into another really important point that I think you're highlighting very clearly is the notion of role modeling and also mentorship and the longitudinal aspect of it all. Is there a formal mentorship program at UMN for the residents, and or is there a program for medical students in general that y'all have instituted to try to spur the interest in orthopedics?
Yeah, so for residents, I've tried various things. Obviously, I've been a program director 16 years, and I've tried the doing assigning to people, and I've tried by specialty. And, honestly, my bottom line has been everybody finds someone, and there's someone for everyone. And I just think I can't find where that chemistry is going to be naturally. But we have over 70 different faculty. And like I said, almost every resident finds a person that they can really confide in and that they can get advice about their specialty. And I think it's the same thing with our med students that rotate through. They find a resident that they can really identify with and that they can trust and they can, ask advice. And so I've kind of gone away from the formal mentoring. And I've really kind of let people choose their own because I just think people understand their own needs better than I do externally.
And I think that's a wonderful point because there is an organic evolution of it that's absolutely critical. And what I tell, I have many students who reach out to me as well saying, oh, can you be my mentor? And I say, I don't think you quite need a mentor, you need an advisor. But the mentoring is something that does evolve with time, with investment, but you have to find the people that you have that chemistry with, and where there's bidirectional flow of exchange of ideas, info, whatever it may be. And so I can learn from you and you can learn from me. And I think that really cultivates the mentoring aspect of it all. So I totally appreciate that, that stand up, letting people find that. What things would you say, or what are things that you would consider need to be improved upon at University of Minnesota specifically? Looks like we have unfortunately, another sort of technical difficulty there. Dr. Van Hees appears to be stuck. At least on my end, she's stuck. Minute. All right, so I think she left, but we'll give it a minute for her to come back in. I hope everyone's enjoying the conversation so far. For those of you who are not familiar with Dr. Van Heest, I'm going to kind of reintroduce her as she's trying to get back on. So Dr. Van Heest is an orthopedic, pediatric, and upper extremity hand surgeon, did her fellowship at Harvard, and actually did her medical and residency training at the University of Minnesota, where she is now not only the program director, but the vice chair of orthopedic education. So it's a real, she's won a ton of accolades educationally, and it's just a real honor for us to feature her on the behind the scenes conversation with the program director tonight. Unfortunately, I think the internet has been not so kind to us, but hopefully she'll be back in just a minute, and we'll be able to continue the conversation shortly. So until then, I'll flip you around so you can see my lovely fridge in my apartment, and then we'll get back to it as soon as she signs back in.
Can you hear me?
I sure can.
Is that an okay?
That sounds good to me.
That was pretty crazy. So here I live in the state of Minnesota where it's below zero, and you're in Miami, and my phone just overheated. And I had to turn on the air conditioning and put it next to it. It said, phone overheated before temperature goes down, and the little thermometer came on.
That is quite ironic, considering that it is around 90 degrees outside and humid at present.
Yeah, ours is, I think we're about the same ourselves. So sorry about that.
No worries at all. The question I was starting to ask you is, what kinds of things do you think need to be improved upon, and what kinds of measures are you taking to improve upon said concerns in general?
Oh, for orthopedic residency education or medical students? Or what do you
for education, or things that you have seen, hey, these are things we can work upon at University of Minnesota specifically?
Well, I would say it more nationally.
Okay.
I think the biggest area that of the next improvement is going to be twofold. One is simulation, which I can talk about at University of Minnesota, because we have a fairly robust simulation curriculum. And that's been highlighted by COVID now, because if you have limited time in the operating room,
right,
maybe you need to learn in a simulation environment. And maybe in order to learn how to do an ankle fracture, you learn your first 3 in a simulation environment, and then you only need to do, 5 to 10. I don't know. You're a foot and ankle surgeon. Maybe you know how many ankle fractures it takes to be competent. But I do think that simulation, the learning curve, it advances the learning curve because you already have a certain amount under your belt from simulation itself. And then the second is competency-based education. So again, I think COVID highlights this, where as program directors, we have to sign off on people that they're competent at the end of training. And what does that mean? If you missed out on 3 months of your, no elective surgeries, did you have enough foot and ankle procedures? Did you have enough hand procedures? Did you? And we said in the past, pediatrics, you need to do 6 months. Well, what does that mean? Is 100 cases enough pediatric cases? And so I've been involved nationally on this, more competency-based education. And that's, it's a hybrid of time and competency, but you have to document that you're competent in the different areas. And as a student or a resident, you have to know what your goals are for competence. Like, what procedures do I need to know to be a competent orthopedic surgeon? What are the core procedures? And so the AVOS has divided it up into the core procedures and then the required electives. So everyone should be exposed to spine and foot and ankle and tumor and all the specialties that none of us really want to do. And then, and then the foot and ankle area or the hand area, there's core procedures that every orthopedic surgeon should be able to do. And, every orthopedic surgeon should be able to do a carpal tunnel and a distal radius fracture and, and an ankle fracture and maybe a bunion surgery. I don't know your opinion about that. But, as a program, I think that's part of what you decide. And as nationally, we need to decide, what does it mean to be competent?
Right. And it goes back to the notion of the trauma experience too. And I do think that the trauma experience helps really shape your ability to bail yourself out of a variety of situations, no matter where you go in practice, whether in academic, private, and whatever subspecialty you do. So I would agree with Dr. Van Heest and in her thought that, yeah, like absolutely being able to be competent in these variety of different procedures, however that's defined, is important because you never know. You're going to be taking call at some point. And when you're the junior member of a practice, academic, hospital-based, or private, you're going to be getting all sorts of things, even if you didn't necessarily do it in a while. So your ability to, again, handle XYZ things is critical and not something you should shy away from, but be able to feel comfortable with, even if you have to do a little bit of, reading, dusting off the textbooks and going back through stuff a little bit, which sometimes we have to do in order to do what's in the best interest of the patient. I like the idea of the simulation stuff because I do think that that's also a huge endeavor that a lot of places are moving towards. Virtual reality is also becoming kind of increasing in terms of use and utility, and I do think that there is probably a rising role for these simulation, VR, and augmented reality type things that to simulate the experience that you may not get, whether in COVID times or not, or to augment the experience you have intraoperatively, so you're not making the mistakes you're not making the mistakes in real time. You are or struggling in real time. You're doing that beforehand and then coming in and make it as smooth as possible.
Yeah, I think the way we have it divided up, it's very strongly based for our junior residents. So we have our G1 skills program, and then our G2s have a very strong pediatric orthopedic simulation because they spend time at the peds hospital. And then we have an arthroscopy simulation that's quarterly, and every resident does a knee and a shoulder. And it's divided up so the G2 does the diagnostic scope, and then the G4 does, they're in pairs. So you have a junior and a senior resident, and the junior resident would do the meniscectomy, and the senior resident would do the meniscal repair.
Right.
You work your way through the program, but the junior resident is assisting the senior resident when they do the more advanced procedures, flap lesion or a stabilization type procedure in the shoulder. And so they're learning as well. And I think that's really augmented our arthroscopy curriculum quite a bit by doing that on a regular basis. And you also make sure that everybody gets the same thing, because as you know, I think students know this too, sometimes you rotate on a service and it's in the winter and it's quiet and maybe you don't get as many trauma cases.
Right.
And or maybe it's fall and you get a lot of ACL cases, and then maybe later you don't get those ACL cases. So to try to even out that experience, I think it's a great thing to have simulation labs just to make sure that everybody has a similar experience.
And I couldn't agree more. I couldn't agree more with that, because it is about there is so many times you might be in surgery with someone, and especially if you're a student or even a junior resident, and you say, how did the attending know to do blank? And how do they know? And you ask the attending, and students and residents ask me, how'd you know to do this? And I say, honestly, I probably couldn't give you an exact answer as scientific as I try to sound many times. Chances are it's the muscle memory and all the different iterations you've had in terms of practice with whatever sort of patient type you're dealing with. And I think that's where the more reps you get, whether simulation or real, the better it is, because then your mind, your hand just sort of know what to do. So sometimes your mind doesn't, you can be thinking ahead, hey, what do I have to worry about for the next part of the case, while your hands are doing what's going on acutely. And I think that often, many times, is how I know what to do, because I know where I need to go. I know the anatomy. I know what to avoid. And I think the more opportunities you get to do that over the course of your 5 years of residency, the better it is, whether it's in real time or whether it's, in a simulation setting.
Well, and if you think about it that way, I mean, we're all looking for what you might call peak performance. And
many orthopedic surgeons have been athletes, and I think it's the same kind of principles where, you know, if you're a baseball player, you go to the batting cage. If you're a golfer, you go to the driving range. And so
Right.
I think as orthopedic surgeons to go to a simulation lab and get the muscle memory and, you know the things that you need to know for those procedures. And again, you know, if you're doing a cadaveric flap, you have the ability to extend the incision and look beyond,
Right.
you know, look where the dangers are and look where
Right.
the brachial plexus is while you're doing a shoulder procedure.
Right.
And so it really allows you to have a greater understanding because we do so many, you know, limited open procedures that you don't, you know, necessarily know where the danger structures are. And that's something that you can learn in the lab.
You're absolutely right. And, you know, just to give an example, you mentioned bunion earlier, and I now do the minimally invasive bunion corrections for a good chunk of my patients. And there's a pretty steep learning curve to it. So even before I did my first one last year, you know, I was they have a cadaver lab down here, you know, one of the companies does. And I was sitting there just doing it over and over and over till I pretty much had the steps down cold. And even then, when I got to the first case, it was still a struggle because, you know, it's a cadaver and it's not the real patient. And so it just goes to show you how important the simulation is. And I'm so happy to hear that you guys have it robustly going on over at University of Minnesota. I do want to ask you a question about the sort of clinical exposure and then the operative exposure in terms of, you know, how much and sort of how often are the residents getting into the OR, how early, and what sort of, you know, autonomy do they get? Because obviously the med students are like, I want the scalp from day one, and whereas is that really the right thing to do? And so can you shed some light on that sort of experience aspect of it?
Yeah, and I think I mean that's a common what you might call misconception in the younger learner is that, you know, you can only learn by doing, and the best way to learn is to just do it over and over and over again. But I think it is important to learn from people who know how to do it well and to do it in gradiated manner. So we get our residents get varied experience. By our third year is our most operative year. So, like I said, our VA Medical Center does more joints than anywhere else in the country. Most of our residents do probably 50 joints and total knees. Those they do it primarily as third years. Fifth years did them when they were third years, so they aren't cherry picking them away. If it's a revision knee or a revision hip, oftentimes our chiefs will cherry pick those. But certainly the primary joints are done primarily as by the third years, and then same with trauma at Hennepin County Medical Center. And those tend to be very resident-run services, so they have a fair amount of autonomy at both of those institutions. And third year is a really good time to do that because you've gotten exposures during your second year and preliminary trauma work during your second year. And so to be able to do it a little bit more autonomously, but with good supervision is a great time during your third year. And then subspecialty is during our fourth year. That's primarily at the university. That's learning about the zebras. You know how to do the horses, but you got to learn how to do the zebras. And then our fifth year, we cycle back and you're in a little bit more of a teaching role. And so that can be helpful for a great way to kind of finalize your residency education.
That's absolutely critical, and I think that it's important for people to understand that, you know, you have to learn the alphabet, you know, before you can start speaking, and you have to learn to walk before you can start running. And you know, one thing that I always share, and it sounds like this is exactly what happens at University of Minnesota too, is, you know, to understand the anatomy is so critical, especially in orthopedics. So you are going to limit the risk of harm to the patient. And if you don't understand the anatomy, then to me, my ability to let a given student get more involved, or resident get more involved in terms of their involvement with the case, is that much more diminished if they don't understand the anatomy. Now, sometimes revision case is very hard. It's hard for me to know the anatomy, but we have a pretty good guesstimate of how that is. So that's great to hear that it occurs in sort of this graded fashion, and that there certainly is sort of a teaching role that develops towards the tail end of the residency program. How often are the residents in clinic in general? Is that vary by service? And is that something that's also emphasized too from a continuity of care perspective also?
Yeah. Again, it doesn't help to be a surgeon if you don't know when to operate. And you only know when to operate if you're the one who's in clinic seeing the patient and evaluating the patient. It varies by service. I mean, I would say in general it's about 50-50, but that does vary by service. Obviously, the trauma services, you're on more call, but you're doing ER evaluations. Again, you really have to learn when to operate and, more importantly, when not to operate. And if you, that's what goes with the first do no harm. And if you, aren't able to discern those patients who are not going to be helped by surgery,
Right.
then, you aren't going to be a good surgeon. And so that's a really important part of the learning process, is learning when not to operate. And so that means some clinic time, and that means some, good communication with your senior residents and with your faculty so that you can learn those aspects and not just the technical aspects of being a surgeon.
That's absolutely amazing, and really important to understand that. I think that obviously we don't just go to clinic to book patients. We go to clinic to see patients and see what ailments they have, find out, but help define those indications. And I think learning that the importance of bedside manner, being a physician first, and putting and treating your patients like they're your family, I think is absolutely critical in helping to improve the outcome for a patient who may have a really complicated case, or even if it's something that's more on the simple side of things. But those open discussions and figuring out, knowing specifically, just like you said, when not to, I think is absolutely important. Tell me what the chemistry is like amongst the residents and the residents and faculty, and then lastly amongst faculty members themselves.
Yeah. So, again, we have a diversity. I think, like I said, everyone finds someone. And so I think that's really great. The residents do rotate through in these groups of 4. So they tend to be very close to the people who are in their group of 4 that year, because you're working as a team, and, I'll take this call for you and you take that call for me, and my car broke down, can you cover this? And, my kid's sick, can you cover that? And so I think that's really important to be part of a team and be able to work together and be able to give and take some. I would say that, the other advice I would have for medical students is, a lot of these team concepts and these professionalism concepts and communication concepts are concepts that you learn as a student. I mean, it almost goes back to what I need to know I learned in kindergarten.
Right.
Concept. But,
Very true.
I mean, as part of the selection process for residency, I mean, that's really what we're looking for are, people who are good people who can communicate, people who can understand that we're trying to help people. Right. We aren't just here to, have fun having surgery. We want to figure out what's your problem, and are my skills to be able to do something about that going to help you. And, we find that, that does the communication skills and team skills do develop during residency, but a lot of it, the interns come in with those skills, and those are skills you learn as a med student. How do you be part of a team? You aren't competing, you're collaborating. I mean, you're trying to work together, with the nurses and with the other members of your team to provide the best patient care possible. So, other things may have been competitive for you, but at this point in your career, it's how to learn how to be collaborative. And that's a really important element that, students learn now, and you come into the residency program to hone those skills. But hopefully you have those skills very strongly, even when you start.
Oh, that's absolutely that's awesome to hear. And how is the and I would also echo the same sentiments that it really is about team effort. I mean, you're ultimately the patient's the most important thing, that everyone's working together to try to take care of, whether it's a critically ill patient, from trauma, or whether it's the outpatient, elective surgery interested patient. So, with that in mind, is the faculty dynamic themselves, sort of between faculty, is it as collaborative as you're describing amongst the residents?
Yeah, we have groups of faculty. We tend to have groups of faculty that, our trauma faculty kind of hang out together. we have certain, I mean, just like all human groups, you have certain
Right.
groups that tend to really work well together, and that tends to be the teams that work together clinically because they get to know each other well and collaborate with the residents because you're dependent on each other, and the faculty are dependent on the residents, and the residents are dependent on the faculty. So that helps facilitate good relationships, and it helps facilitate good patient care. So I think trying to cultivate those relationships is an important part of the residency program and professional development.
Oh, that's great to hear. Let me ask you one kind of, and this got brought up as well as a question is research required at UMN, and what sort of opportunities for research are available in terms of whether it be biomechanics lab, basic science, more clinical study involvement? What sort of research availability is there as a whole?
Yeah, so research is required for every resident in the United States. The ACGME requirement is one publishable project. And so the way that we approach that, actually, it was pretty interesting. About 5 years ago, one of our residents, Ben Williams, he graduated this year. He's going to HSS for a foot and ankle fellowship. Wow. And he looked nationally at all the residency programs and how many publications per resident per program, and published that data. It's in JBJS, and he categorized the research experience as whether it's a dedicated month or whether it's longitudinal, or if there isn't a strict set aside research time. And the most productive means for resident research was longitudinal. And so that's what we've instigated. So, for example, our G1 residents, when they rotate at the U, they get 1 day per week for 3 months. So that they can, and then they have a they have a research curriculum that all the G1s go through. Dr. David Polly is a spine surgeon. He's in charge of the G1 resident research this year. And and then that provides you the ability to get a research project up and running, because you can schedule research meetings, you have a dedicated day, and then you get a half day per week, or sometimes it's 2 days per month on your G2 and your G3 rotations. Wow. And that it varies a little bit by institution, the way we set that up. And then your G5 year, we have what's called the career rotation, and you get 1 day per week to kind of put the icing on the cake at the end. And we found that that's been giving us very good resident productivity. We do have labs. We have 2 biomechanical labs. We have a gait lab. We have a variety of different resources. Each of the different hospitals has separate research programs. So.
Hey, Dr. Van Heest, your sound, I think, cut off a little bit. I didn't quite hear the very end of what you just said. I got stuck at, I lost you at the 2 biomechanic labs. I think you're back.
Yeah, now I can hear you. I lost you there for a minute. Not sure what happened.
No problem. It's the weather. It's the humidity and the clouds here in Miami. I'm sure it's creating a ruckus.
Well, it's crazy 90-degree hot here too, so maybe it's on the Minnesota side.
Yeah, we'll split the difference. We'll say it's both.
Yeah.
So you were saying that you have 2 biomechanic labs and then gait analysis lab, and so obviously opportunities like crazy for students to get involved. Yep. Or residents to get involved, students too.
Yep, and students as well. Okay. Each of the sites has their own research teams, and so you can join whichever site it is if you're interested in trauma or pediatrics or the various different sites depending on what where your interests lie.
That's absolutely awesome. I certainly I love doing research and do a ton of do collaboration up the wazoo and try to get students, residents, and everybody involved, especially as they come on rotation. And I really like the fact that you've implemented a research time like per week. That's actually something I'm starting right now on the foot and ankle service here in Miami. And because a lot of places do have, did you guys ever have like sort of like a 2 or 3 month block like in off years? And did you find that there's a difference between what you're doing now and having that block time specifically?
It's interesting because Dr. Mark Swinkowski is editor for JBJS, and he's our previous chair. He's still part of our faculty. And he has been a long-time believer that dedicated research time just becomes dedicated golf swings. That's what he says. And so he has been an advocate that you need dedicated time, but it needs to be, spread out so that, because that's how research projects tend to develop. They tend to, they go in kind of spurts and, you work on things and then it's stalled for a little while. And so he's been a big advocate. We just hadn't formalized it as much as we have in the last 5 years as far as having a full longitudinal program. But he's kind of been against dedicated time since he was a chair here about 15 years ago.
Okay. Yeah. And it's interesting because I used to think that when I first started 5 years ago in practice that, oh, hey, I needed this academic time. And now it's actually, I've realized, okay, well, as long as I have the projects and I've got a team working on it and I can sort of stay on top of myself because I tend to be fairly organized, you have to integrate it into what you're doing day to day because you're constant. There's a sort of a harmonious tension amongst personal life, professional life, and like what you want to do academically as well. That it's just it's really hard to just cultivate a day alone to do XYZ things. And so I agree with that longitudinal nature as well, at least from just a personal experience. I think. There's one question we have as we're kind of wrapping up here. Can you just highlight again, Dr. Van Heest, the virtual opportunities that y'all are having up at Minnesota? Someone's asking. I think they joined a little bit on the later side when we started.
Yeah, so we have a 4-pronged approach to applying to our residency program. We have the 10 students that are U of M. We have 2 scholarship students. We have 50 students who have signed up for virtual, and then we'll take about between 20 and 30 students through ARIS. And the virtual experience is going to be in 3-week blocks. I'm doing a town hall on it next Wednesday at noon, and then we'll record that and post that. And I'll discuss a little bit. Everyone will be doing a patient case presentation and participate in a journal club and be able to meet the residents that are on the rotation that you are assigned to during that 3-week period. It's meant to be about 10 hours per week. It's not a full-time deal. It's just meant to help you network and get to know our program, get to know some of the residents. But the med students are busy. You're doing your own rotations, and this is just meant to give you an opportunity to augment your experience and get to know some of the residents and faculty at our site.
That's absolutely awesome. And Dr. Van Heest, I really want to thank you for your time tonight. I also want to encourage everyone to check out Dr. Van Heest's town hall about University of Minnesota. If you're interested in it, send me a direct message and I will send you the link to sign up for that specifically. And I will also be doing a little story about it too in the next day or two. And so again, you can reach out to me to get the link for the information on that and the timing of it specifically. But Dr. Van Heest, thank you again. It's been absolutely amazing, kind of hearing how things are going up at University of Minnesota. Please continue to stay safe. If there's anything else I can do, please, don't hesitate to let me know. And thank you again for your time tonight.
Thank you, Dr. I really appreciate that you're doing this ortho mentor. I think it's a great role to help the medical students navigate. It's not an easy time in your lives, and it's even a little bit harder when you are doing it virtually and in the COVID environment. So I wish the best of luck to everybody in all your different situations, and I hope you choose to be an orthopedic surgeon and even better to be a hand surgeon. All right.
That's absolutely wonderful. Thank you again. Have a great night and stay safe.
All right. You too. Thanks so much.
No problem. Bye-bye.